Hello, everybody. It was very freezing cold today, so I don't want to freeze during my flights. So, thank you very much. Thanks to the organizers for inviting me. And I'm going to talk about few interpretations of the rare case scenarios in lung cancers, what I have come across, and I will be asking questions rather than giving answers because this is not yet clear what is the best way to take them forward. So, well, we understand the histologic and molecular heterogeneity, and we have this diagram seen in the past, you can say, presentations. So, I wanted to just emphasize here that these frequency of these mutations sometimes give some clues what we are dealing with when we are not able to do a true biopsy, especially when you do a liquid biopsy. This frequency can tell that probably you are dealing with adenocarcinoma versus squamous cell carcinoma. Just to emphasize the mutation, that is the PIK3CA mutation and PTEN alteration, which are commonly seen in squamous as compared to the adenocarcinoma. So if you encounter them and biopsy is not feasible, then definitely, probably you are dealing with a squamous cell carcinoma. But that's a small bit of it. We understand the importance of the routine diagnostics, the expanded diagnostics, and the idea is to find the target, but life is not very easy. So let us try to see scenarios and see what best we can come out of with these questions. So this is a 65-year-old, a non-smoker male with non-small cell lung carcinoma, metastatic, EGFR L cross triple negative, PD-L1 and found to have a classical MET exon splice site alteration. But if you see that the patient also have other alterations like CDK4, FGFR4, MDM2 amplification. So now when we find these alterations, we are very happy that yes, I have the drug which will work for the patient very well. But response rate versus the duration of response is what we are looking at. So sometimes you may see the major clones, which are the driver clones or the driver alterations which have the dominance. You may see responses on the imaging, but it is not lasting. And the explanation can be given by other alterations. In this particular case, if I see that most of the time, whenever the patient progresses on TKI, we tend to give immunotherapy or combination of immunotherapy with chemotherapy or target therapy like bevacizumab or ramucirumab. But patient having MDM2 amplification is one of the criteria where the hyperprogression can be expected. So these information sometimes are very handy, not only to find your current treatment, but what not to give actually. So similarly, in the previous talk, we have talked about the RNA-based NGS testing format as well as DNA-based testing, and the importance has been already discussed, so I'm not going to repeat them again. We'll go to our second case here, which is a unique compound EGFR mutation, which is in this case, EGFR V834 and L858 are compound mutations. So we know that when you encounter these compound mutations, the expected duration of responses is not again that great. So rare alterations, again, we should look into a true prognosis of these alterations actually when we are counseling the patient. Interestingly, the patient also have this ATM truncation mutation. What does it signify? Nobody knows about it. Does it reflect that the patient may be eligible for PARP inhibitor in future? Probably yes, but a big question to discuss about in a molecular tumor board may not be upfront, maybe in the later lines of the treatment when the patient fail on target therapy, especially the EGFR TKIs. Normally in my clinic, when I see patients like this, when you have compound mutations, I tend to combine TKI with chemotherapy upfront. I do not wait knowing the fact they are going to respond or fail very soon. So we have seen a couple of successes, longer duration of responses when we go upfront with osimertinib with TKI with the chemotherapy in these scenarios. So another interesting scenario here, we have a compound mutation of EGFR S768I and G719C. Again, compound is a big challenge, but also we have a ALK fusion mutation. So now it is a concomitant mutation, compound and concomitant mutation together. So how to handle these scenarios? Again, a big question. Drugs which can act both on EGFR and ALK like brigatinib can be attempted, but are they truly working? So if you go and see the literature, STRN ALK fusion is again a rare mutation. It is not classical EML4 ALK. So papers have shown that alectinib has not worked for STRN ALK fusion that great. So these are rare mutations, has to be dealt in a rare way. We cannot take it generic. If you find a mutation, it does not mean that the drug is going to work. So again, you have CDK6 amplification, which is a possibly a potential target, but may not be. Again, so concomitant is a well-established thing where EML4 ALK and EGFR has been reported. And in this particular paper, they have shown that the overall survival or the PFS is very, very short. So we know that we are dealing with very complex situation. I think in these scenarios, early on usage of chemotherapy may be beneficial rather than allowing the tumor cells to grow and come up with some more alterations, which may be difficult to handle later. Another interesting case, again, a chronic smoker with a concomitant mutation, which is L858R and EML-ALK fusion. So once we have the fusion report, I tend to try to see if the report also talks about the variants. In this particular variant, this is variant #5, which is very equivalent to variant 1, which may show responses to the classical crizotinib. But again, the concomitant mutation EGFR L858R will be a challenge. So we know that there are almost more than 90 fusion partners of ALK which are reported. So even for the EML4, these are the variants which we all should take care of in them, especially the variant 3 where we know crizotinib does not work. So just to give you a flavor of the possibilities what we may encounter. Another interesting case, we have a 55-year-old gentleman who progressed on gefitinib, afatinib, and chemotherapy, and who had exon deletion 19 to begin with. Did not work at all. And when we investigated why it is not working, what we came across that the patient have two resistance mechanisms. One is EGFR amplification in itself and ERBB2 amplification. So what can we do about it? Yes, this is a very interesting case, and where we gave the patient osimertinib and herceptin together, it worked, and the patient did good for 3 years actually. But if I see that this patient also have BCL2L1 today, somebody was talking about, but it's an equivocal amplification. So mutations sometimes crop up and we do not know how to handle them, but they do carry poor prognosis. Another interesting case, a 71-year-old female, again had EGFR mutation, was given osimertinib, and progression within 3 months with brain metastasis. So now, most of the time, we tend to go ahead with the standard next line of therapy, that is ABCP. In this case, if you see that the patient have a PTEN alteration, which may be the you can say a de novo mutation, which is causing the osimertinib to not work actually. Similarly, if we go with the immunotherapy approaches for these patients, they may not work that well because PTEN also is a biomarker for poor response to immunotherapy for that matter. So again, these are interesting cases, and then let's talk about another interesting case. This is a 44-year-old female with EGFR exon 19 deletion, was given osimertinib, had a wonderful response, lasted for 1.5 years, progressed, a biopsy was done and showed BRAF AGK fusion actually. A BRAF mutation, which is a secondary acquired mutation, which is a known cause of resistance to EGFR. So now these kind of mutations can occur. So what are the options? Should we stop osimertinib and give BRAF-based therapy? Or should we combine them together? How to overcome these challenges is a big question. Should we just switch to chemotherapy for that matter? Maybe yes or maybe no. So, but in this case, what we did, we just gave a single monotherapy of trametinib, a MEK inhibitor. It worked for 3 to 4 months, but again, progress, which we knew. We are not confident to combine osimertinib with so many drugs together. So this is something which we are learning how to do that, how to go about it. But interestingly, if you see the other alterations in this mutation, gives me some clues, which is a mixed clue. CDK12 truncation mutation is a good biomarker for response to immunotherapy. That is one. On the other hand, CTNNB1 is a poor prognostic biomarker for response to immunotherapy. CDKN2 and NTPA loss is a biomarker to tell that this is a cold microenvironment. There is not much of infiltration. So probably immunotherapy may not be a good choice for this patient because of mixed genomic alterations. So again, interpretation is sometimes not that simple and straightforward, and these are real case scenarios. So another interesting study, exon 19 deletion with BRAF mutation. This is a concomitant mutation in a treatment naive patient. Patient also have EGFR amplification of more than 12 copies actually. So now what are the options we have for the patient? So again, similar situations, common challenges. So now we have a 57-year-old female non-smoker progressed on chemotherapy. Liquid biopsy was done. It was a squamous cell carcinoma on tissue biopsy. So we have this PIK3 alteration and KRAS alteration. So PIK3 alteration, as we know, it is matching with the expected squamous cell histology, and we were very confident. But can we really apply the best cancer therapies to this in the real case scenario? May not be. But if you see that the patient have KRAS alteration, which is activating the MAP kinase pathway, and PIK3 is activating the mTOR pathway, so you cannot target the dual pathways together. We have tried in clinical scenarios to combine trametinib and everolimus, which is very, very toxic. So practically, we don't have good answers to these scenarios. But yes, just a flavor of it. But these learnings sometimes are helpful in this scenario, like a 70-year-old female male non-smoker, metastasis to brain mets. Biopsy was not possible because of the poor performance status. But the patient have a similar PIK3C alteration, and it was suggestive of that we are dealing with a squamous histology rather than adenocarcinoma histology, and PD-L1 was 80%. But if you see this mutation, the patient have a lot of mutation, including the FBXW7, PIK3C amplification. But all these alterations, even if the PD-L1 is 80%, when you have PIK3C alterations, you may not see good responses to immunotherapy. That is a challenge. So if you have a biomarker, which is a good marker for response, but you have another biomarker, which is not a good marker, then it becomes a big question what to follow. Just to summarize in slide that activation of Wnt beta-catenin pathway or activation of PIK3 pathway are one of the important mechanisms for resistance. MDM2 or EGFR pathway are mechanisms for hyperprogression, and loss of function PBRM1 added to BRD7 or c-Met pathway are mechanisms for good responses to immunotherapy. So let us see another case, a very interesting real case scenario. 69-year-old female, PD-L1 of 35%, was given chemotherapy first line, given chemo IO, and given chemo second line, progressed practically. And the patient have CD74 NRG1 fusion, a very rare fusion to find. So we know that the NRG1 is a ligand to HER3. And once you have the activation of HER3 mutation, practically there are not much of options to offer except chemotherapy. But in this case, we offered the patient afatinib along with the FESCO, that is trastuzumab and pertuzumab, to inhibit the combination or the heterodimerization of HER3 to HER2. That was the innovation what we did for the patient actually. Yet to see the results, but this is our foundation solid and the foundation liquid. A lot of concordance that we can see in these two cases, and it was done almost an year apart. So it reflects that this clone is not sensitive to the chemotherapy or IO therapy for whatever matter. Another interesting case. So 72-year-old female who has received 2 lines of chemotherapy have RET fusion. We are very happy to see RET fusion these days. Patient was offered pelhazatinib actually, but have serious side effect. PD-L1 was 20%. So now, if we just come close and see, this patient also had ERRFIU1 truncation mutation. Many of us, even me, was not aware till I encountered this mutation actually. So this ERRF1 protein is an important protein which inhibits the pan-EGFR kinase domain actually. So EGFR1, EGFR2. So if this is altered, if this is truncated, the function is lost. So there is a constitutive activation of the EGFR pathway. Even if I use any RET inhibitor for that matter, the EGFR pathway is still active. So the option what we gave to the patient was a combination of three, which is again a unique scenario. We gave them the option of lenvatinib because palazetinib was quite toxic to the patient. Lenvatinib has to be relatively tolerated with the patient, along with immunotherapy and afatinib for that matter, which will have pan-HER, you can say, inhibition. So again, a unique combination we did, yet to see the results. Last case, this is just to share that we are very happy to see when we see that mutation actually. Such a waterfall plot is so impressive. So this is my last case and I will stop. This is again a metastatic case with PD-L1 of 0. The patient have BRCA2 alteration. That is a somatic alteration with KEAP1 STK alteration, which we know that the patient should not or would not do good on immunotherapy. Again, MTAP loss and CDKN2A loss. So the patient was given IO and chemo. We knew that the immunotherapy was not that great. The patient had good response in the first evaluation, that is around 3 months. And on subsequent evaluation, there But if you see, there's a SDHA rearrangement, which is reflecting that this loss of function is affecting the hypoxia-inducible factor, what we normally see in other syndromes. It's well proven. So this patient may benefit with VEGF therapy. Adding a PARP inhibitor makes sense because it's a somatic mutation and we are running out of options. So it was a scientific rationale. But this report tells that the MTPA loss and CDKN2A loss reflects a cold microenvironment, and that is why we did not see very good responses in this patient with immunotherapy. So many cases to discuss, but I just shortlisted this with the timeline what was given. With that, I thank you all for your kind attention. And just to tell that the reason why we chose immunotherapy for this patient was the TMB was 23 mutation per megabase. So TMB alone is not a good biomarker. The best response rate, what we can see is in the range of 30%. And we know that the patient who have high TMB and PD-L1 low, they do not do good, but they still have STK11 and T53, you can say enrichment, which exactly was seen in this case, STK11 and T53. So again, literature is there. It's just that we have to see every case, go back and read more, which is practically not all the time feasible. But yes, interesting scenarios every time actually. Thank you very much for your kind attention.
Any questions?
That was
Ashish.
The only concern I had was that, like, for example, when you look at combining 2 treatments or 3 treatments, we, as a clinicians, the first question which comes in our mind is, okay, are we going to end up in some unknown toxicity, which we do not know? So how do you talk to your patient and how do you get the consent?
So it's a very interesting question. We try to see if we do not enter into an overlapping side effects scenario. If it is there, we know TCAP plus TCAP brings a lot of toxicity, especially the cardiotoxicity, and acute coronary syndromes are quite common, well reported. So we try not to combine TKI to TKI at that common, or we try to make a regimen or a protocol which is truncated, half the dose to begin with, or we try to give a treatment-free interval and then we combine. Sometimes we go back and see literature where they have done phase 1 trial To give you an example, there are certain trials where the people have combined crizotinib with osimertinib. So if you see the literature, you will find that they have given crizotinib post-progression osimertinib, but continued osimertinib. So sometimes we learn from the phase 1 trial experiences. Sometimes we use our common sense. Sometimes we try to use lower dosage, but we explain the patient these are the possibilities. But most of the time we are using these options when we are running out of options actually. So it is not that it is upfront we are offering them to do an experimental approach. Documentation, yes.
Yes.
The following points. One is that standard of care is exhausted. That is the first point. Second is that whatever is being proposed has a scientific basis, but has not been proven to be effective. And the third point is that there could be potential side effects that we do not know. That could include permanent disability and death. You should write that, permanent disability and death. And then take the consent, then it should be.
Yeah, added to that, we usually give reports from our clinic, we keep a legal disclaimer that there are no actual guidelines.
So please understand, legal disclaimer is illegal. Under the X-ray or imaging also, radiologists write not valid for medical legal purpose. It is nothing is like that.
I agree.
So you have whatever, unless you have taken the patient's consent and it includes these points, then that is the only thing that will keep you safe.
There was an alternate point that was put across on a board that every patient who undergoes a precision oncology consult should have an internal ethics committee approval as well. That is the extent where we are right now.
So-
Could be so difficult to do. I'd rather not say.
So I would
but-
suggest that you document it in a multidisciplinary tumor board. Go into the ethics committee, not required.
Yes.
Now the reports come from the field of science lab. So, and then we interpret individually and then in tumor boards. So many times the patients, especially like we all get emails saying, "Doctor, you tried everything, but my last report said you should try trametinib with bevacizumab. Shall I try that?" So patients think actually that's a recommendation for them, and so what are the legal things around that? And many times, like, it's very difficult for me to tell that I may not agree, or I have a different take on this, or I'm not comfortable trying this combination because I've never done it before. So.
Can I give you an example which is unrelated? Here the treatment as patients, people, normal individuals feel that they are not in height and they want to undergo surgery to increase their height. And there are accepted surgeries available. But in India, if that surgery is done, and then the patient's parents go and complain, then the doctor is found negligent and then so sometimes doing things in the best interest of the patient can land you into trouble unless it is documented.
Dr. Amit, it was a great talk. Thank you. How confident are you in giving something that is based on a phase 1 trial or a preclinical data? Because most of the time, these are the complex scenarios we see. You cannot fall back on RCTs or guidelines. I mean, that is what we see in real life. So, and most often we also get vehemently opposed in tumor boards saying that this is just preclinical data or, not phase 3, phase 4. So how would you go about that?
So again, I also face similar challenges. It is not that easily accepted. So I always wait till the patient progress on whatever is being offered actually. So again, it becomes kind of a waste option, a waste basket option. You or last resort options. So again, same challenges and difficult for me also to find the right combination. But scientifically, if we try to find answers, and we have learned over the past few years, not decade, that the combination of target therapy is going to be the next option, not the combination of chemotherapy. So how we have to learn if we don't learn, then we cannot improvise actually. So we have to try at least. Dr. Pravesh, if you want to comment on that, thank you very much.
Ashish, one of the things which we do and which we don't realize, we do treat patients till 6th line, 7th line, 8th line in our clinic. And that we do in many tumors, including lung cancer. And really no one will have those evidences of the moment. If I go back to see that 6th line, is there some evidence for it? For drug evidence is there. What 6th line, those drug, it is not there. So there's a challenge, but we all do it. This concern is fair of this combining and giving. So the Western world, they do a good thing. And I think so, I hope we learn from that, because problem is that we learn all the bad things very fast with them. So we do have a lot of ethics committee and some very good ones, someone not so great one. So I was having discussion with Dr. Kurzok, who does in phase 1, and they said they have a blanket approval. And again, this combination, there's another challenge. So she calculated and gave a calculation that if you use all these combinations and then put N to power whatever is required, so we may require more than 1 lakh studies to answer this question, that something works or not. And we all know that is not feasible. So what she has a blanket approval from IRB for a protocol like this. So she can combine. So she has, whenever she has these multiple mutations, she combines, and she shared many of those examples, and not for specific combination. She has for any combination you try, but you keep those documentation. The problem is that this is a huge problem, but does IRB understands that? Unfortunately, no, because for them till now, they have understood there has to be trial, there has to be randomization, all the things has to be there in the protocol, the dose, the schedule, the change, the toxicity. No, here it is not known. Here only things that you documented what you're doing, but that's a solution. But problem is that solution is not available to us. So that's the moment ethics committee approves. The good thing is in today's time, if you have academic study, then the whole sole responsibility is of ethics committee and the patient and the and the doctor. It's possible that at the end of the day, someone may prove in the court. So again, no one knows the brain of judges. We have seen all kind of ruling in the past. So it is possible. But in general, if ethics committee is involved, because that becomes a neutral party. Not only it is a neutral party, maybe in today's time for academic study, they have maybe more power than Supreme Court. The way it looks like, the way the kind of power they appropriate. So if ethics committee gets involved, then yes. The problem is that ethics committee understanding that this is a good solution, no, because as on date for them, protocol is that everything needs to be there. That's a issue there. Yeah. So, but I agree with you. Unless they say in law, unless you put with the judges, you don't know what they will give the ruling, and then you know, okay, where the law stands.
Thank you, Dr.